Welcome to the Ideal Plus session on case-based clinical reasoning as a curricular approach to active learning. Let's start with what is clinical reasoning. It is the mental process that happens when a doctor encounters a patient and is expected to draw a conclusion about the nature and the possible causes of complaints or the abnormal conditions of a patient and a likely diagnosis and actions to be taken. So, what has actually happened when clinical reasoning occurs? According to a theory which is called the dual process theory, and contains two elements. One is system one thinking, and the other is system two thinking. System one thinking is the rapid pattern recognition. It is a subconscious process based on experience and intuition. System two thinking is a slow analytic reasoning process. It is conscious deliberation based on pathophysiological and epidemiological knowledge. Now let's review how the clinician's memory actually works. How do experienced clinicians think? They have a mental repository of many disease representations in their long-term memory, and they are called illness scripts. And an illness script is a mental image of all facets and natural courses of a disease based on foundational knowledge and personal experiences with patients with that disease. So the memory stores illness as scripts, as single chunks with one label and not as a series of information bits. And the working memory looks for illness scripts that resembles a new case. Now let's explain what the working memory actually is. If we think of the memory architecture of a person, there's three components according to the Atkinson-Shiffen model. There's a sensory memory, working memory, and a long-term memory. The sensory memory is very rapid. It's about hearing, seeing, smelling. The working memory basically is a processing unit that processes information to be stored in the long-term memory, and it needs to be retrieved when necessary. The working memory can really only process very few elements at a time, whereas the long-term memory can store many, many elements if they are structured well. So the working memory's function is actually to create that structure for information bits to be retained in the long-term memory. And many things in the long-term memory can be decomposed. If you would have one illness or an illness script, you could say, that script contains many elements. If a doctor thinks of diabetes type 2, there's many aspects of diabetes type 2 that can be listed, but it's only one label, and the working memory can use that as one label to be processed at a time if the clinician has that experience with such patients. Now let's look at how a clinician might think. So here is a clinician, and in that clinician's head are many, many illness scripts, you could say, all based on experiences with patients, but also on knowledge that's retrieved from education and textbooks. Now this doctor encounters a patient. Here's a patient, and the doctor starts asking questions about the complaints of the patient. And the patient would gradually build an image of what happens. Would say, well, I have a swollen knee. I have no other complaints. It's just suddenly occurred, and it has occurred twice before. It's very painful, and it happens at night. So the doctor starts combining those elements to their illness scripts in their mind and suddenly thinks, could it be gout? So that pops up in the mind and can happen very rapidly. If the doctor has no idea what happens, then an analytic process happens. Analytic reasoning is very slow. um, he would, the doctor would think of, could it be an infection? Could it be osteoarthritis? Gout would be one of the possibilities, but would have to think of what are the features that this patient shows, and do they comply with what I know or what the textbooks say? So that's a slow process. If you would um, combine all in one model, this is a model from Crosscarry in 2009. Think of the process as a patient presentation leads in the doctor's mind to a pattern being processed. And if the patient's illness is recognized rapidly, there is a pattern that is recognized because it aligns with an illness script in the long-term memory. Then there could be hypothesis testing to make sure that it's truly that illness. But very quickly, the after asking a few questions and looking at physical examination, the doctor can make that conclusion. If the pattern processor says, well, I don't recognize this, then causal reasoning needs to happen. And biomedical knowledge is retrieved either from their long term memory also, or from textbooks or maybe articles in the journals. So a causality construction is made, leading to the need to also test hypotheses. And if the hypotheses actually show that it's not, um, the causality is different, then it needs to go back to the pattern processor. And again, new causal reasonings need to happen until an hypothesis is confirmed and the diagnosis is made and the management decisions can be made. And that information, again, is added to the illness scripts in the long term memory. So our next patient might be recognized because of this experience. Now, think of how should we train preclinical students. So the problem is that clinical experience is needed to build illness scripts, and preclinical students that prepare for clinicians do not have that experience. So what do is we train with simulated cases that resemble the natural course of actions to create early rudimentary illness scripts, raw illness scripts that can get shaped in practice. Just imagine this as a raw illness script before practice. Now, during practice, that raw illness script is actually elaborated with examples from cases. With a lot of experience, actually, the scaffolds that have been built in early phases of education can be left out, and the clinician can increase their knowledge by new patients and adding to their long-term memory. Now, case-based clinical reasoning education is focused on that process. We work with small groups that regularly meet, 10 to 12 students, and we discuss one case per session of 2 to 3 hours. Students take the lead in preparing and conducting the session. By turn, we have 2 or 3 of the student group together acting as the responsible peer teachers. Now, there's also a regular teacher, a clinician, who acts as a consultant, only interfering when asked or when the group gets off track. All cases are carefully designed and are available in 3 formats: a student version, a peer teacher version, and a consultant version. This is the student version of a case called a 28-year-old woman with diarrhea. Now, this is the peer teacher version. This is the consultant version. We have actually elaborated this process in many places, in Utrecht in the Netherlands where it was developed, but also at other places. Here is an example of a demonstration of a session of CBCR in 2012 for an international group. Here's another demonstration of the same type of education in Granada in Spain. In an earlier session, an earlier seminar of Ideal Plus. Here's a version, and here's a version of what we do currently during the COVID-19 pandemic in Utrecht. Now, what does a typical case in CBCR look like? What is the format and what are the ingredients? Of course, there's a title that always includes gender, age, and main complaint. We state a general objective for the case. There is preparatory reading materials and reference to previous knowledge of the student. The case starts with a brief case vignette, usually the patient's problem presented at very often a family doctor. Then the questions unfold during the case, following the clinician's analytic thinking pattern. There's hints for peer teachers, there's background information for consultants, and there's regular handouts or oral information with new patients about new information about the patient. And there's short presentations by the peer teachers. This table is a typical table that is very often used in CBCR cases. And you can see that there's information, 1, 2, 3, 4, 5, 6, that could be information bits from history taking or from physical examination or from diagnostic tests. And the doctor has hypotheses in mind, usually more than one, in a differential diagnosis. And what students then discuss during the session is which information would match with which hypotheses. There is an extensive description of this whole education in a book in Springer that is an open access book. Is free to download. You can Google it and you can find it and you can read everything about all the details of case-based clinical reasoning. Done in Tbilisi, Georgia in 2013.